So welcome everybody. Thank you so much, like I said, for coming. My name is Courtney Kowalchuk. I am a therapist. I have partnered with the San Marcos Unified School District to put on Virtual Parent Academy for you guys, which are hopefully good, lots of good information, really helpful for our parenting toolbox. And I have been doing this now for quite some time, somewhere around 10 years. And so I love doing this. Parenting is one of my passions. And so we're going to go ahead and jump in. Like I said, if the best, easiest way is if you keep your microphone on mute, and then if you want to say something, go ahead and chime in. I'll get a little notification that you want to say something. And if you don't want to use your mic, go ahead and use the chat. That would be a good way to communicate. So, welcome everybody. Again, tonight we're going to do a virtual parent academy on depression in adolescence. So, this is going to be more probably more so geared towards clinical information and helping guide you guys to understand what this looks like in students, what we see in schools and at home, and really just to get some knowledge under your belt about this particular issue. We will have lots of ways to help you if you're struggling with you have a student or a child with depression, or if they've been diagnosed with depression. There's also just some general good information for those of us that have depression as parents, and to help our kids just with kind of some coping skills in as it relates to stress. So if you don't have a child with depression, but you're here, welcome anyway. I still think you're going to get some good information. And at the very least, this will help you kind of pinpoint and just give you some more information to be able to um, yeah, widen your knowledge in the area, and will help you if you ever need this information in the future with your kids. I think next week, if I'm not mistaken, or next class in 2 weeks is going to be kind of the same thing, but on anxiety or anxiety disorders. And so, like I said, I kind of lean heavily on some of the clinical information because that is my wheelhouse. I am a psychotherapist. I work in private practice currently. Um, and yet, hopefully, there's going to be a lot of practical stuff and just ways to kind of get through this. I do like to give you guys a little bit of information about me. I'm a board certified clinical psychotherapist. I've been doing this for about 14 years. I do specialize in treating children and adolescents, which not all of us do. I also have a particular specialty and expertise in trauma as well as parenting. So I've got kind of some of my certifications up here so you guys can see that, some of my experience. I did a lot of training at Rady Children's Hospital, San Diego, at the outpatient and inpatient clinics. And I've worked with school districts doing psychotherapy, both individual, group, and family for the last 14 years. And yeah, that's where a lot of my experience draws from. I served in the US Air Force, so I've got some stuff there. And let's kind of jump into what we're going to talk about tonight. So, generally, we start having this conversation about depression and anxiety because we see that this happens for some kids. And we want you guys to be aware, right? We want parents to feel like they have the information. Maybe you showed up tonight because you feel like you might have a child who's struggling with some of these things. Maybe you've already got a diagnosis. Maybe you're just looking to get information. And so, whatever reason brought you here, I'm really glad you're here. I think, showing up and being with us at 5 p.m. on a Wednesday, you could be doing so many other things. And maybe some of you are. I see some people driving or, prepping food, and that's okay too. If you just want to listen, I'm just glad you're here. So, what I really want you guys to do is be able to learn some of the depressive symptoms in youth. And this is really just, again, for you as a parent to be able to spot things and kind of like be ahead of the game if you do have a child that eventually struggles with this sort of thing. I really want you to be able to just gain understanding on how to best support them. Now, in particular, I'm going to talk about suicidal ideation and self-harming. And that's specifically because we've had a lot of parents and people ask, how to deal with this within the context of depression. And so I find generally that because this is unfortunately happening more frequently than we would all like, it's best to just have a little bit of knowledge on it so that either you can help your own children if they're struggling with these things, or you can help friends or family if they've got kids who deal with any of those, what we would call symptomology with depression, because suicidal ideation or suicidal thoughts and self-harm sometimes is coupled with depression. And so we kind of find that arming you with that information is really helpful. We want you to be able to network with other parents. That's a big deal. I find that a lot of these groups, one of the largest benefits is just getting questions answered, talking with other parents. You might have the same issue that another parent has, and just being around other parents, I find is really, really helpful, especially if they have similar challenges as you. I also want you to be able to just get resources to support your student, improve their coping. And so I'll be able to give you guys some books that I really enjoy, things that you can take home and read. Also, we'll have a take-home exercise that you can help your child with if they struggle with this sort of thing. And that's going to kind of be where we start. We've got about 2 hours. We're only about 10 minutes in. Normally, what I like to do is if I get through and we hit the 6 o'clock mark and I haven't heard any questions, I usually will stop there and kind of pause. And then typically, again, maybe 10, 15 minutes at the end. If I have lots of questions and engagement throughout, it won't leave as much time for that. But just know there is a time and a spot for you to ask questions and feel like you're heard and get answers to your specific situation, because I love doing that. That's the whole reason why I do these and why I'm passionate about doing these. I want to give you real-time answers because I think that's super helpful. Um, I know that not everybody has a child and adolescent therapist at their fingertips, so it'll be cool to answer any questions you guys have. Okay, so we're gonna go ahead and jump in. Typically, I like to start with either this type of discussion question or a quote. Tonight, I really want to start with just getting some information about who's here, what kind of problems you guys might be struggling with, what kinds of things are bringing you into the session today. And just like your experience with what we're talking about. And generally, that's just going to help guide me and give me some feedback as to, what you guys are looking for. And it'll just kind of get us talking. And I don't necessarily have to talk at you guys the whole time because I don't think that's as beneficial. So, what I want to know is for the parents that are attending tonight, what types of behaviors does your adolescent or teen show that concern you? And obviously, we're going to talk about this in the context of depression. What are some of the behaviors that you see that are concerning? And yeah, I wonder if, like I said, if you don't feel comfortable chatting on your mic, go ahead and throw it in the chat. I will read all of that. And with these types of behaviors, what impact does that have on you as a family, as a parent? Any behaviors that your teens or kids show that are really concerning for you in a context of depression? Okay, thanks so much, Nancy. Sixth grader gets mad to do stuff like going to a play. He's there smiling. There's a cookie in the air when he's mad, and then he's fine. At school, he's an angel. Um, okay, so totally might not be classified as depression, but just a concerning behavior that you have. And to do stuff like going to a play. So it's almost like he fights going out or like going to engage in doing things. And then once he's there, he's having a good time. I would almost argue, yeah, okay. And so I would almost argue that most of us, I don't know about, I do this, right? Like it's this like, oh my gosh, I'm exhausted. I don't want to go out, right? I don't want to, I've been working all week or whatever. Um, but then I go, right? And I tend to feel better. And this actually does fit. So thank you so much, Nancy. While your child might not have clinical depression because of this thing, it does fit into the context of talking about it in this way that like depression really does make us, it's like we don't want to do the things that we know are good for us, right? And arguably, I think that's just kind of a people thing. The path of least resistance, the thing that's easy sometimes or that feels good is not always the best, right? So I do think that relates in that way, right? And also just I think kids could exhibit some of these behaviors that are like, oh my gosh, like it's not depression, but like, man, this is really concerning that he doesn't want to go out. He's kind of getting so mad, and exhibiting these types of behaviors, and that's like bizarre or just annoying or whatever that is. And I think the reality is like, does that happen every time? Does he kind of eventually like learn, okay, wait, actually, I know I don't want to go now and I'm frustrated because usually I think with kids, it's because they have to stop what they're doing in the moment, right? And sometimes that's like really fun or exciting or it's playing. And so it's kind of understandable from that context that kids are being interrupted to leave. And for us, it's like, "Ugh, well, come on, like we're gonna go have fun." But there's also this element of like really just validating that, like, I know we're interrupting something really fun. And it might even just be like reading his book or playing a game or watching a movie. But if we can say, I really get that. This feels like it's interrupting what you're doing. So is that where kind of the anger and being mad, frustrating, being frustrated comes from? And he might be able to say yes, or he might be able to say, no, it's not that at all, right? But I think that's probably where that's coming from because this is super common in kids, right? They're being interrupted. So, definitely not clinical depression, but a wonderful example. And I hope that kind of helps a little bit. That's definitely, a concern and totally valid. Um, oh, okay. So I have another parent that says his 15-year-old son looks sad all the time. He doesn't want to talk. He hasn't wanted to talk to him. He's isolating and refuses to see a therapist. Okay, so that is where it gets tough because if we have kids that we sense might be dealing with some sadness and then they refuse to see a therapist, that makes things difficult. And I think this is going to be a perfect session for you, Lynn. So thank you so much for coming. And I hope that having this information helps you. I might be able to give you some kind of tips or strategies to try to get him to see someone. They don't always work, but they could. And then I think just more context, right? So like I think what we could do is maybe glean some information from the presentation if you're still concerned at the end that like maybe he really is dealing with some depression. What I would say is I'll be sure to include some maybe helpful strategies to get him to see someone because sometimes the best thing to do in those scenarios, and sometimes what I offer as a therapist is it's really hard to force kids into therapy because that generally doesn't work, right? Then they just get angry and they want to resist, and then that's not helpful at all. But I think sometimes what I tell kids is, hey, I know I'm probably not the best parent that you need, and I want the therapist to help me, right? So sometimes I almost like, you can tell them all the things that I need to change, and then they'll help me change, right? So it's almost this like bypassing of you don't even have to talk about yourself, right? Just talk about me and like how I need to fix things. And sometimes they're like, "Oh yeah, like I'll jump on board with that. I'm going to go tell her everything about what you need to fix," right? And I think sometimes that's helpful. We'll see if it is or it isn't. But also I think maybe getting somebody that he does really have a good relationship with to maybe kind of plant that seed, if he's got like a coach or a friend or a mentor or somebody in the community or another person in the family, like maybe somebody again to kind of plant that seed with him. Sometimes we can use that as well. But at any rate, that's really, really hard. And I know it's hard to watch and hard to deal with as a parent. So, um, yeah, I'll have some information for you too, just kind of how to deal with that. Okay. Anybody else want to share kind of concerning behaviors, maybe things that you're concerned about in the context of depression with your kids? If not, we can kind of move forward. I hope that those things were helpful. I really appreciate the feedback, and it might give us a general sense of where people are at tonight. Okay. So, this is actually kind of linking us from one of those parent questions. We had a parent who kind of gave a concerning behavior, but it's like, okay, but this is not depression. And what I really want to be able to do is help you guys understand what depression is and what it looks like in kids, because it is different. It does appear different. And what I will say is, um, there are some, I think, maybe traditional ways of thinking or just some historical ways of thinking, some just like societal ways of thinking that depression or being sad or seeing some of these things, dealing with your feelings, it kind of was previously thought of as a stage, right? Something that kids just grow out of. Oh, it's just a phase. She's really sad right now, but she'll move on. Or, oh, he's really, angry, bored, sad, but he's just gonna grow out of it and it'll be okay. Um, I think what we're obviously realizing now is that that is just not something that's supported by the science, right? Typically, when we talk about depression, and again, I'm talking from the context of clinical depression because that's my wheelhouse as a therapist. The reality is, kids don't grow out of that type of behavior. And the best thing that we can do is intervene and intervene arguably earlier, right? The earlier, the better. Because what we don't want to do is treat kids for depression if they don't have depression. But at the same time, we want kids to get supported because early intervention, particularly with children and adolescents, means a better outcome in the long term. And what that really means is if we give kids an outlet and a space to talk and have that as like clinical assessment and get that help, typically it's better for them in the long run, and the depression might not elevate, right? It might not escalate or progress into, say, more severe clinical depression or cyclical depression. And that's kind of brings me to this next point that what I will get to today is I will really help you guys distinguish, hopefully, between, there's kind of some depressed mood, there's some sadness, there's some crying, right? There's some certain things happening, versus what we call depressive syndrome and versus clinical depression. Now, this is all going to be with the caveat that you would need a professional, you need an expert, you need a psychologist, a psychiatrist, or a psychotherapist to diagnose depression or any of the other mental health diagnoses. And so, what I want people to understand is I'm not trying to teach you how to be clinical and assess your child, but just to get lots of good information to help guide you, right? Help you use that gut instinct as a parent, help guide you and help you do your due diligence, right? So, it's just going to be something that gives you a little bit of information. I will also say every child is different. You guys know this, especially if you have more than one. It's like the second one's born and you're like, what is even happening? This is so different. I experienced that with mine. And so every child's unique. And really, what I can say is there's a degree of normative depressive type behavior in most adolescents and teenagers because they are going through some of that the most dramatic developmental shifts. And typically, this is what we see as moodiness, mood swings, right? Sleep issues, behavioral changes, cognitive changes, more isolation or withdrawal. A lot of that stuff is really normative when we look at the context of development. And so I've kind of hit on a lot of these points in the last couple of sessions, just kind of getting you guys to understand like particularly when we talk about 10 to like 15, right? Maybe even a little earlier now. Kids are going through some of the most monumental change, right? Both hormonally, physiologically, psychologically. And so what we want to know is, wow, things are changing dramatically, and yet what is normal and what is not. Um, what I will say is this goes along with this kind of normative sadness, unhappy mood. This is very typical for human beings, especially due to situations or loss, grief, um, life transitions, right? This is very, very typical. So, what we do again want to help you guys kind of differentiate, even just on a kind of simple scale, what's going on, right, in their life. Has there been the loss of a family member or of a close friend, or did we just make a really big move? Or have there been a lot of really small moves that kind of feel, lend some instability in my kid's life? Have they recently gotten injured, or has there been a health issue in the family? Really just kind of looking at what's going on, and is there like some sort of trigger or circumstance situation that I can point this behavior to. And if you can, arguably, if it's within kind of normative parameters, which again, you may not know what those are or be able to diagnose that, but having some sort of known situation or circumstance really kind of makes okay, well, it would make sense because like, grandma or grandpa died a month ago or 6 months ago, or there was a divorce 2 months ago, things are drastically changing, right? And so it's going to kind of give us this like needle to our compass. And so just kind of pay attention to that, right? Is there something going on that could allude to why this child is feeling this way. Now, what we do want to also delineate for parents is that the problem it comes in when it's in excess, right? And it's like, okay, well, what's excess? Well, that's going to depend on each child. And again, this goes back to clinical diagnosis and assessment, which is really important. And at the same time, does it look excessive to you? Does it feel excessive to you? You're going to use your gut. You're going to use your best judgment as a parent, and only you can do that. And I really want to bolster your confidence in that area. That after tonight's presentation, I do think you will have a very good understanding of whether or not it's excess or not. What I will say in the context of this conversation is that overall, clinical depression is relatively low in children. It's under 1% in children. Now, what we do see is not a dramatic increase, but a quite of a bit of increase and rise in adolescence, right? And like I said, that peak in adolescence is very commonly almost always related to that developmental process, right? And we'll get into some of the details of why. And at the same time, what we do know is that clinical rates of depression are very, very low in children, and they do rise somewhat in adolescence. So, some of the most recent data. Again, data is kind of always behind a few years because it takes time to gather that information. And so most recent numbers that I've seen really are kind of in the 2020 time frame, which I will say things have changed in the last 6 years since 2020. But the prevalence in the United States in 2020 for clinical depression was 12% of adolescents. I'm realizing I've got a typo here, so I'm going to change that real quick so it's not confusing. Um, 12% of adolescent children in the United States aged 12 to 17 have had one depressive episode. Majority of kids and adolescents develop without any clinical depression concerns. So, I mean, what we're seeing is around 10 to 12%. And that is still quite low in terms of the population and in terms of prevalence. And yet, what we do know is that I see those 10 to 12%, right? And so, if we were to look at, a class of course, they don't come in hundreds, but right, 20 kids, you're going to have two children who struggle with clinical depression. And so, what we do want to help you guys understand is that this is not a scare tactic. I don't want to scare anyone. I don't want anyone to feel like this impending doom of depression for your student. And just kind of give you some real numbers. The reality is that the prevalence and the overall rates is quite low, and yet it does rise in adolescence. So if you have a kid who's maybe tween, as we call it, preteen, somewhere in the range of 10 to 13, to me, that's the most drastic change psychologically, and you might see a higher prevalence there. And yet, we're going to see that kind of level out as kids' hormones regulate, all the reproductive organs and hormones start to regulate, sleep starts to regulate a little bit later into the teen years. And so, you might also see more significant changes in that developmental stage of like middle school range. And so hopefully that's helpful for those of you that have a middle schooler. I often tell a lot of my families and the people that I work with, if you have a child who is in that flux, right? They're in the transition from being an elementary or an elementary age child, right? Anywhere from 0 to how old are we? What would we be looking at? We would be looking at like fifth grade, right? 0 to fifth grade, child, sixth to eighth, going to be middle school. So that range of kids is going to be a little bit more, I think, struggle with a little bit of this more of these problems because of the developmental changes happening. Okay. So what we're going to talk about a little bit, and we're just going to kind of dip our toe in the science of depression in the context of children and adolescents. As I've said to you guys, this is my wheelhouse. So this might we're going to try not jump too far into the clinical conversation because I don't know how helpful that will be. But if you've got questions, go ahead and throw them in the chat. Um, what we know about adolescence, and this is going to be really helpful, especially for younger kids, right? As they're changing. Individual and social change is predominant, meaning that is the biggest factor happening in children and adolescents' life, right? Because all of those changes biologically, physiologically, psychologically that we've talked about, those things are the primary thing happening with our kids. And so what we want our kids to understand at this age, right, is that things are going to change. You're going to feel different. You're going to have thoughts and feelings and reactions that don't necessarily feel normal, maybe even for them. And the reality is that puberty is happening, right? We also see like prepubescence, there's changes, or we call it adrenarche. Um, this is the period typically before girls get menstruation, but the reality is hormones start changing as early as 6 to 9 years old. And so that is really the onset of what we call pre-puberty. And then we have like full-blown puberty, right? Which is typically happening anywhere from like 9 to 11, 9, usually around that age. And we see girls going through puberty earlier than boys, which means typically we see rates of clinical depression 2 to 1 in girls. Girls are seem to be more affected by depression or depressive episodes. And a lot of this is correlated to hormone brain relations. And again, this goes back to pre-puberty and puberty that period of change biologically in girls and in boys. But again, this puberty thing really happens to change the way kids feel and the way that they think and the way that they're able to cope with what's going on. And so, what we also talk about, puberty is happening or pre-puberty, right? And then we have the changing of schools and cohort, which is something that I think became also quite more popular and higher in prevalence during COVID when children were being taken out of schools, they were being moved schools because of all the things, whether it was vaccine related or whether it was just we couldn't, take them. They couldn't go to this school, they had to go to this school, they were being rezoned. There was a lot of displacement in schools during that time. And so what we know is with all of those changes combined with larger schools, we see that there is an incredible demand on kids when it comes to transition during these periods. And so, one of the things that we talk about when we talk about changing of schools, changing cohort, larger schools, this really means like less stability and more exposure to change, right? So, the reality is there's more kids, there's more demand, there's more pressure. And this kind of leads to peaks in exposure to what we call psychosocial stress, right? So psychosocial meaning psychological and social, and that is basically how kids are reacting to their social environment. And so I don't even think we can have this conversation without talking about technology and social media. And that's one of the classes that we will give during the Virtual Parent Academy. It's a really popular one. It's one that I'm super passionate about. But we do know that the exposure to psychosocial stress, particularly in the context of technology and screens, has really gave us a dramatic increase in some of these particular diagnoses or what we'll just say symptoms or behaviors. And so we know that things are changing. We know that technology and social media absolutely plays a part. And so I didn't even put that on here as one of the bullets, but the reality is that that exposure is also increasing rates. And so we want to kind of pay attention to why is this happening? It's affecting again girls more than boys. And so there's kind of we can delve into that conversation when we talk about social media and technology. But the reality is hormones are changing, the environment is changing, right? They're going from elementary school to middle school to high school. And those are dramatic changes in the context of kids, right? And so we're seeing that they're at a higher stress point, they're at a higher stress baseline. And so it's just important to kind of pay attention to why this is happening and why clinical depression could affect a child's brain at that age. One thing we also know is that I've talked about this because I gave a class on sleep. If you're interested in seeing those previous classes, I know they're recorded, and I definitely think Annie at some point has the link for where those will be posted in the future. And excuse me, in the context of the sleep conversation, I did share with the parents that were there, the sleep onset mechanism becomes impaired. And typically what we see in normative adolescence, the circadian rhythm is changing. And really what's happening in a normative, right, typical kid without depression, they're having a harder time falling asleep, right? They're having a harder time to fall asleep, which is why we see a lot of we call them like night owl, right? It's really hard for children and adolescents, especially post puberty, to go to sleep before 11 p.m. There is a scientific basis to that. And what we do see is that the onset mechanism, meaning the thing that helps kids fall asleep, is actually impaired in a lot of depressed adolescents. So kids that have clinical depression, we also find within the brain that the sleep mechanism is impaired. And so what we see is they decrease growth hormones, right? We see that that means cortisol increases, which cortisol is the stress hormone. And then we see that there's an increase in the time until sleep, meaning there's that sleep insomnia, if you will, in depressed adolescents, particularly depressed adolescents who've had suicidal ideation. And so what that means is really for the context of this conversation that depression can actually change and alter the sleep. And arguably, sleep can alter depression, right? And how that presents. And so what we want to do is just pay attention to how are our kids sleeping? Do we notice some of this stuff? Can we explain some of this stuff with sleep hygiene, which would be in the conversation we had last time? Or is this something more serious? Is this something that would lead us to believe that there might be something else going on? There is a genetic component when we talk about depression, particularly with children and adolescents. There is a 3 to 4 times increased risk if a child has a parent with clinical depression. Obviously, we're not going to know with every family because there's a lot of undiagnosed depression and clinical depression or depressive episodes. And yet, if we know that there's been a parent that has diagnosed depression at any point in their life, that there is a hereditary link and our child might be likely is at a risk 3 to 4 times that risk. And so what we know about these like hereditary or genetic predispositions is that affective, right? Things that affect the affect, the mood, right? These disorders run in families. And so this is probably why, this explains the doctors will ask you, oh, what about family history? Is there a parent with it? Is there a grandparent with it? And this is kind of so about physical health disorders as well. But we do know that when a parent has clinical depression, the child is at an increased risk. We also, there's also an element of what we call co-occurring issues. And so while in the context of depression with adolescents, it's not a huge conversation to be had right now. The reality is that clinical depression often co-occurs with other diagnoses. And that is just helpful in the context of like, okay, I know my child's been diagnosed with ADHD, or I know that my child's been diagnosed with being on the autism spectrum. I know that my child has an diagnosed anxiety disorder. And so what you might say is if you see some of these behaviors or symptoms, it might be saying, okay, maybe this is one of those scenarios where there's going to be some co-occurring things or things that run together. Um, we also know that anxiety is thought to play a causal role with depression. And so what that means is that we understand that a lot of people who have anxiety also have depression. And so this goes back to just helping arm you with if you've got a child and you know they have an anxiety disorder, you know that that's been diagnosed, you've talked to someone, they're getting help with that. It is possible that there's some depression that's causal through that link. And what we talk about in the context of depression at this age is that mood issues in some way with kids this age can be described by their growth, right? Their increased capacity to self-reflect, to um, find that they're feeling more empathetic about how they're affecting other people, right? This increased cognitive capacity in kids during this stage also can describe some of the mood issues. What that means is this could not be depression, but it could be their way of going, oh, like this is what's happening. I'm actually starting to self-reflect and I have more of this like cognitive capacity. And so that could be something that's leading this as well. Now, what that would mean is it's not necessarily a clinical issue. It might just be developmental, and we would kind of want to look at that as well. We can talk just really briefly There's a change in neurotransmitters with people who have depression, particularly and obviously clinical depression. And neurotransmitters, kind of brief little conversation about that. They're responsible for communication in the brain. Serotonin, as we know, is responsible for mood, sleep, appetite, and more. Norepinephrine is linked to alertness and attention. GABA slows down brain signals. And there's almost always a disruption in the balance of neurotransmitters when we see people who have clinical depression. And so, what we understand is that this is why medication is sometimes or often recommended, right? Because what we see is there's this link between neurotransmitter levels and the clinical symptoms of depression or clinical symptoms of anxiety. And really, what that means is there's something going on in the brain, right? We know that there's differences. It's kind of leading us back to that conversation that we had initially, which was this usually is not just a stage, right? That's why the data is really not supporting this because we see structural and hormonal differences in the brain, which kind of gives us that oomph to say this is not just a stage, this is not just a phase. They're not just like a sad kid that's going to get over it. Typically, when we see clinical depression, there's a neurotransmitter difference, which really lends itself to we got to use something a little bit more effective, not necessarily medication, but definitely not just kind of waiting for the phase to pass or, um, run of the mill, sadness or grief, right? We want to try something a little bit. Oh, okay. I'm kind of looking back in the chat just to make sure. If anybody has any questions about this stuff, go ahead and feel free to throw it in the chat. We're going to kind of shift the conversation and talk a little bit about what some common symptoms of clinical depression are. Now, again, I don't want you guys to feel none of this is up to you to like assess and figure out. We really just want you to get some tools and some information under your belt so that you feel better making those gut reactions, those decisions for your kids. Um, and so this should help you just differentiate a little bit, right? Give you a little bit of that information in terms of does my child have depressed mood, or is my child having some sort of maybe more clinical depressive episode or clinical depressive issue? Now, the way to kind of see this without clinical assessment would be look at some of the symptoms of the depressed mood. Does your child feel lonely? Do they talk about feeling lonely? Do they cry often? Do they fear or say that they fear doing bad things or messing up? Do they feel the need to be perfect, right? Is there a level of like perfectionism, possibly academically? I would say more often than not, you're going to see a lot of this stuff come out with school because that's kind of a child's primary realm right now. And so they might feel the need to be perfect. They might feel unloved or say that they're unloved. They might believe that others are out to get him or her. They might feel worthless or talk about feeling nervous, fearful. They might feel guilt. They might be self-conscious, which I will say when we talk about self-esteem in the context of adolescence, it is developmentally appropriate for children and adolescents to have poor self-esteem, right? To be self-conscious. It is part of the developmental profile for every person to go through that. And so the reason I emphasize that is because I get a lot of parents, absolutely understandably and naturally so, they call or they're really concerned because their kids have low self-esteem. Now, while that's a concern, it is somewhat normative. We want to help parents understand we can sit with some of that because to be self-conscious and to have low self-esteem is very normative of normative child development. Now, again, this goes into the excess realm. Is it in excess, right? And again, that's kind of a harder thing for parents to dissect or to assess. But the reality is just helping you understand if they've got a little bit of that or they've got some of that, right? It might calm your mind or your heart a little bit to know, okay, I've seen that my kid's really self-conscious, or I see that they struggle with self-esteem. Now that I really know, like, this is really normal. It's absolutely normal of the developmental like process for them to feel this way. Okay, like now I know it's not just this like weird thing that, is wrong with them. Because I know even as a parent myself, I struggle with this, right? Something happens with my daughter and it might be at school or whatever, and I start to worry about her, right? Because I'm like, oh, is this like a concerning thing? And most of the time I can check against all of my knowledge and go, no, she's fine, right? Like this is completely normative, and then I'm able to kind of move past that speed bump. So I'm just kind of trying to level with you guys that while a lot of these things will still be concerning, right? Absolutely, for a child to feel suspicious, sad, worry, fearful, unloved, right? Feeling worthless, feeling nervous, crying, feeling lonely. These are all really, really understandable things to be concerned about for your child. And so I get it. And of course, by no means am I telling you not to be concerned about those things because there are children. And I think for most parents, it's impossible not to feel concerned about them for probably all of us. And so, with that being said, this should just kind of normalize a little bit of that for you, right? That depressed mood in adolescence is quite normative. Now, what we see is, and where it kind of crosses over into the clinical realm, and this again has to be assessed by an expert, but clinical depression is depressed mood or irritable mood in children, because this is the other piece that depression looks very different in children and adolescents than it does in adults. I hear tons of kids who say, well, I'm not depressed. Like, I'm not crying all the time, or I'm not depressed. I don't sleep all day, right? The reality is that clinical depression in kids looks different. And one of the biggest difference that I've always seen is irritability. Kids who have constant, chronic irritability, not just with one parent, not just with one person, but everybody, right? You're going to see irritability across the board. And I also see boredom in a lot of kids who have clinical depression, but this is going to be like extreme, right? It's not like your kid comes up once a day, is like, oh, I'm bored, right? It's this feeling or this kind of cognitive process of sharing they're chronically bored, right? And that one's a little bit of a more rare component, but irritability and depressed mood most of the day, and then we talk about every day, right? It's not like typically when we see clinical depression, there's a lot more strictness in the length and the frequency of the depressed mood episodes or of the irritable mood. So it's not going to be like oh, they're fine at school, but then they come home and they're completely irritable, or they're not having this type of mood at school, or at home, but then they go to school, right? It's this like across the day. Also, how long has this been going on, right? If it's like, okay, we've had a month, 2 months, 3 months of this kind of depressed mood. Typically, when we talk about clinical depression, a longer, there's a more of a length. The frequency is also going to be most of the day, most of the actual day, and then most days, right, of the month. And so that's kind of what we're looking for when we talk about clinical depression as well. Anhedonia, which is our way of saying kids are not interested in what they used to be interested in, right? Kids don't do the things that they used to do. Kids don't enjoy the same hobbies or the same sports. Now, this is one that I find most kids during this stage, right? They're changing anyway. And so this one is a little bit harder to spot because of all of those changes. Kids give up a hobby and they want to do something else, or they're not interested in, roly-polies anymore and they want to be interested in anime or whatever that is. So we have to kind of really assess that with some expertise as well, because really we're looking across the board at not just change, but true withdrawal from those activities, just in a wider variety, right? Wider manner. Changes, so the bigger things here too in clinical depression is changes in weight, and we're talking like dramatic changes in weight that couldn't be described by normal development. And that's going to be a significant amount either lost or gained. So a lot of parents, I talk to them about appetite. Is your child eating? Do they have what seems like a normal appetite, normative appetite? And then I would also say in the context of younger kids, when we look at appetite and weight and food, nutrition, we look at it in the context of a week instead of a day, which I think kind of trips people up as well. We also look significant we look significantly in the context of clinical depression at sleep, right? So we're talking about sleep is going to change with development anyway, but we're talking about maybe more severe intermittent waking, which means falling asleep, waking up several times in the night. Maybe more extreme like insomnia, not being able to sleep. Let's see. Didn't someone have a question, or was that just kind of a mic that was going off? Irritated at school too, right? Yes. So if there's irritability, again, we're going to see irritability with not just one person, but irritability across the board. And typically with clinical depression, we're going to see the same symptoms at school and at home. Um, let's keep on trucking. So we talk a lot about psychomotor agitation or retardation, but that's not actually something that's going to be very common. What that means is kids are either like we find with depression, particularly clinical depression, kids are really slowed down. The movement is really slowed down. Now, what I will say again, this is very rare. But it's either a kid is moving so slowly that other people notice, or they're moving so quickly that people notice, right? Again, I will say that's pretty rare, even in adults. We're going to look at decision-making ability, concentration, and focus. What does their, now again, in the context of children and adolescents, their prefrontal cortex is not fully developed. It's not going to be fully developed until anywhere from 25 to 35. And so what we do know is that kids in general, lower focus, lower concentration, decision-making ability is less robust, right? And yet at the same time, what's normal for your child is are they not able to focus or concentrate on school or homework when maybe 6 months ago they were doing kind of fine with that, right? You really want to look at that in the equilibrium or the context of your own child because kids are really going to struggle with that in general, especially if they're younger. As they age, they're going to be more able to do this as the prefrontal cortex develops. We also talk about repeated suicidal ideation or self-injurious behaviors, and this is kind of why we start talking a little bit of self-harm and things like that in this particular context. And that is because suicidal ideation, which is thoughts of being dead or not alive or going to sleep and not waking up, these are all kind of examples of that. Self-injurious behavior is burning, slapping, bruising, biting, cutting, those types of things. Head banging, right? We have a lot of these things, but these are symptomatic of clinical depression. We recognize that these things do correlate with kids who have depression or adults that have depression. And the reality is, what this means is if you're having a child that has struggled with suicidal ideation, saying, oh my gosh, I just want to kill myself, or oh, I just don't want to be around, I want to go to sleep and not wake up. These are hints to us that something probably more serious is going on. Now, what I will say, this also is important in the context of social media, technology, what kids are exposed to. Kids are exposed to this more than they used to be. And that's, I can tell you with my own anecdotal research, the more and more I work with kids and the longer I work with kids, kids are much more exposed to this than they were, say, 15, even 10 years ago. And so the context of what I want to get to today is there a known history of suicidal ideation self-harm or what we call self-injurious behavior? Has there ever been a suicide attempt or plans of suicide? Any writing about suicide? Um, Talking about it in text messages with friends or in on social media? Has there ever been drawings or journaling about these things? Now, some of you might say, I have no idea. And the good news is that if you don't have any idea and this has never happened, then we're going to kind of assume, okay, this probably hasn't happened with my child. Now, most kids, right, by its nature, self-harm is by nature secretive, but there's typically some signs that we can recognize. And typically, I will tell you, in my experience, other kids are actually quite good about reporting suicidal ideation or self-harm in their friends or in their kind of cohort. Because I cannot tell you how many times I've been made aware of kids who do this and it's because of another child, right? Typically, this is not like a tattletale thing. It's almost always, in my experience, related to compassion, right? The kid feels some sort of fear or worry for their friend, and so they share, typically with a school counselor. That's really 9 times out of 10 where I'm seeing this. And the school counselor is kind of alerted of these things, and then they kind of do what it is in their due diligence to do. But the reality is, it's secretive, but almost always I find a friend is going to say something, and that's typically how these kids are getting help, at least in my experience. And so I think one thing that would be important to note is there a family history also of completed suicide or attempted suicide? And that's going to kind of change things as well, because there is that hereditary component. And I would just, if this is happening, again, I could just say, like, I'm sorry if this is happening to any of the parents that are here. I just, it's a hard thing to deal with. And at the same time, I've worked with so many kids who have had either thoughts of suicide or self-harm, and we're able to help them move past that and grow and get some coping skills. Because again, this goes back to that like cognitive ability of kids. And if they're exposed to certain things, what we really want to do is make sure that they have a robust just what to do when that comes up, right? Or if they're exposed to it. And so um, I will kind of take a little segue into talking about self-injury or self-harm. And of course, I always try to tell parents if this scares you, I hope that just having the conversation can arm you with some information. I don't want to fear monger or scare anybody. And at the same time, I think this is just information to put in your parent toolbox. Um, what I typically start out the conversation with when we talk about self-injury, suicidal ideation, those types of things, typically self-harm, because we see this, I would argue, more commonly in the last at least 5 to 10 years. We know that there's been an uptick since 2008. And in the social media and technology conversation, I will touch on why we think that is. But since 2008, there's been a dramatic increase in emergency room visits, particularly for suicidal ideation and self-injurious behavior, and obviously an alarming increase in girls. And so, what I want parents to know, and kind of what this disclaimer is what I will say is we want you to take it seriously, right? And yet, I also want parents to understand that you can seek help, and you should absolutely seek help if you have a child who's experiencing this. And also, there's this disclaimer that usually, typically, self-injurious behavior or self-harm is not always related to the wish or desire to die. And so we talk about self-harm in the context of suicidal ideation because the two behaviors for a lot of people are linked, and certainly they're both symptomatic of clinical depression. But what I will say is when kids self-harm, some people, especially parents, always they immediately react and they respond with, my kid wants to die, right? They're in danger, they want to die, and this is really serious. Now, while the it's serious part is absolutely true, I just want parents to understand that self-harm is typically not related to a desire to die or as a suicide attempt. Now, the importance of that is if you have a child who's self-harming, we want them to get help with a professional, but we also want to help us understand that this is different than a suicide attempt and that it's typically not related to the desire to die, more so as a desire to cope, right, with their emotions and with what their brain and body can't handle, so to speak, in their perception at the time. So, what we also talk about is it is developmentally normal for kids of this age to withdraw and pull away from their parents. We know this to be true. It's part of the developmental stage. It's part of what we call individuation. Kids at this age are psychologically recognizing that quite possibly subconsciously that they are not a part of their parents, right, anymore. They are their own human, they are their own being, and it's completely and totally normative and quite even to the necessary, right, for kids to withdraw and pull away from their parents because developmentally that's what we want for them to be more independent, successful adults is we want them to pull away from that parental unit. Now, what that's coupled with is it is not normal for them to withdraw or isolate for long periods of time or in excess, right? Now, when we talk about like kids need to pull away, to individuate, to be by themselves, but it's not normal for them to completely withdraw and isolate, right? We want to like coax them out. We want them to come maybe do some family dinners or family activities on the weekends. If that's not happening at all and there's complete withdrawal or complete isolation, this would could be considered excess, right? Because if they're by themselves all the time, it's not just individuation and becoming their own person now. Now it's absolute social isolation or withdrawal, and that is not good for kids at in any state. It's not good for adults. We know that, social isolation is used in prisons and it's incredibly damaging. And so what we do know is that the withdrawal and the isolation to an extreme degree is incredibly damaging for kids, and it can be incredibly damaging for someone who's experiencing clinical depression, right? Because we know that it makes it worse. So, I said this a little bit earlier. When you find that they're tending to withdraw and isolate for really long periods of time, what we do know is that sometimes that's correlated with self-harm or self-injurious behavior because by nature it is secretive, right? They're going to be spending lots of time alone in the bathroom, in their bedroom. These are kind of some things to look out for if they're isolating and withdrawing for really long periods of time. They might be wearing inappropriate clothing for the weather, right? The kind of classic long sleeves in summer, hoodies in summer, or long pants at the beach, right? We're going to be looking at things that kind of don't fit. You might find sharp things in their room. You might find razor blades or razors. You might find just different cutting tools in their room or in their belongings. You might notice unexplained but repeated cuts, bruises, burns, things like that. These are kind of going to be, if you see one of them or more than one of them for sure, this might be telling you, this might be a good idea to seek out some help because these are some of the symptoms or some of the signs that you might see. And what we want to do, and again, there's also this kind of trend recently, and probably in the last 5, maybe 10 years of with the bracelets. There's a lot of kids who hang out in these circles, and instead of doing long sleeves, they do the massive amounts of beaded bracelets, and it covers this area where they would normally cut or self-harm. And the reality is, you could ask, right, if your child is exhibiting some of these things. What I would say is do not wait. Address the issue right away. You want to be, however, right, you want to be calm. You want to reassure them that they're not in trouble. This is like, we're okay, right? I'm going to validate the child, right? I can understand this. You must be really scared. You must be really angry. You must have a lot of feelings. I don't know, right? But there's something, this seems like something's going on, right? We don't want to pressure them to talk. We don't want to lecture or put them down. Um, while we might want to do those things initially, I will say your feelings are valid if and when you find out that your child is doing this. You might feel shock, you might feel denial, anger, frustration. You might feel lots of empathy or sadness. You might feel that parental guilt kind of creeping in. And the reality is, all of those feelings are valid. All of those feelings are okay. This is an incredibly difficult thing. I cannot tell you how many families I've talked to where I have parents, they're upset. I have parents cry. They're totally feeling all of the emotions because this is a really, really sad thing to deal with and a really hard thing to deal with. And so let's deal with your feelings, right? They're valid, but we don't want to like act out in any of those ways towards our kids. We might say, I'm so sad that you feel this way. And like, what can I do to help? Right? We need to address this. Like, we need to go talk to somebody. This is, something that I've learned. I have to keep you safe. Right. And so that is kind of the way that I would approach it if you ever have to deal with this and or have dealt with this or are dealing with this. Um, and so, what we also know is that attachment issues or other stress, right? Family issues, um, family repression of emotions, these things are all more likely in adolescents and teens who engage in self-injurious behavior. So, families that have high stress, families that have kind of predominant family issues, families that are kind of have that mentality to not talk about their feelings, sweep things under the rugs, right? These are the families that we actually see a higher rate in kids that do this. And if we think about it, right, it in my mind as a therapist makes a lot of sense because when kids are feeling a lot of this family stress or a lot of this like repression of emotion, they don't know what else to do, right? And so a lot of the times this is solved by, oh, okay, well, I can hurt myself, right? Because this is something that will make me feel, this will help me cope. And while to you and I, with our fully formed brains, right, it doesn't make a lot of sense. But with kids, this um, is especially true of kids who have family issues or this tendency to like sweep things under the rug because it is secretive and they don't know how to deal with things otherwise, right? And they're not feeling like they're able to talk or get their feelings out. And so the reality is, if any of these things are happening, remember the thing that I could remind you the most is feel your feelings, maybe take some time separately if you need to, kind of sort through those, and then don't wait and address the issue. Seek help from a professional because if we're talking about like suicidal ideation and self-harm, those are kind of what I would argue as higher risk factors and things that we want to address immediately by calling your doctor, getting them in, getting some resources. A lot of therapy clinics, if you talk to, whoever you get on the phone saying, my child's dealing with this, the risk factor is going to elevate and they typically will go to the top of the list in terms of waiting or getting help. And so we definitely want to do that quickly. All right, let's see if we've got questions. I don't mind if you answer the question. Oh, okay. She's saying, I don't mind if you answer the question out loud. Um, so a parent says, that's my daughter. I've seen messages about suicidal thoughts. I've tried to talk to her. I see it on the weekends when she's home. She's always alone. Her grandma works. She's always wanted to. Okay. So if you have, okay, so this is a good question. Thank you so much for asking this question. Maybe also Annie can throw in the if you have that information of the, is it Care Solace, Annie, that San Marcos partners with? Um, So if a parent has questions, you have a child that you know maybe has had these thoughts, they're not self-harming, but they seem depressed. My best option is going to be hopefully they have whatever insurance they have. I would first make an appointment with the pediatrician because they might be the easiest to get in with to then give you some of the referrals that your insurance accepts. Because that's the whole thing is we have to figure out what type of insurance. Typically with like Medi-Cal or with some of the insurances, there's going to be kind of an easy path for the pediatrician to then refer you. Um, there's also a program through, I think, the district that is called Care Solace. And if I'm not mistaken, they can also link you with therapists to get some help. And I think Annie's going to put that into the chat for you. You're so welcome. I'm so sorry that you're dealing with that. I would also say like school counselors are a good place to start because they might have like kind of a list of resources as well. Um, so those are kind of the three options I would start with is like make an appointment with the pediatrician. Just let her know, like, I noticed that some things are happening. Maybe not necessarily like telling her that you've read things, or I would just say like, hey, I can feel that there's something going on and I really want to help you. And would you want to go see a therapist? Would you want to talk to someone? They could definitely just listen and be there for you. I would probably start also with school counselor, finding some of the resources through them. But those are some good ways to start. He says he doesn't want to talk about it. I would talk to the counselor. She's,
Excuse
oh,
me.
uh-huh.
Hi. I don't know if you mentioned this, or if I missed it, but I actually found that it's also helpful to connect with the like send out an email to the teachers, the vice principal, counselor, anyone who can be of support because our children spend so much time at school that if they ever need are having a difficult time in the class, and they need to step out and talk to the counselor. I know my daughter's counselor was great in that she gave her like her business card and kind of gave her like a one-time pass. So if she needed it, she needed to talk to her in that moment, that she could step away and get that support. And it turned out she never used it, but for her to have it, I think was not only a good support for her, but also for myself, because, it's hard to focus at work or do what we have to do when we don't know if our children are having a good day, a bad day, or whatever it may be. So contacting the school and developing those closer relationships so that they can be our eyes and ears, I think is really helpful.
Thank you so much, Maria. Absolutely. That was something that was kind of being sent, I think, in a message just to me. And so they mentioned the school counselor thing. And so I think it's an amazing like testimony to hear that you had such a good experience with the school and that the school counselor was so helpful for your child. I absolutely would go there. And I appreciate you sharing both your experience and your daughter's experience because that's really helpful to the other parents to just hear like this worked, right? This was helpful. And Annie also put in the chat the information for Care Solace, which is another program. And if a child's not ready to talk about it just yet, I would kind of the reality is if there's a safety concern, I would encourage just you talking to the school counselor, and then maybe they can kind of pull them and normalize and encourage her in that way. Because we don't want to just like leave it hanging or leave it up to her. Um, but I would definitely say, okay, like I love you, I respect your opinion, like, and then kind of share that stuff with at least the school counselor to say, like, do you think you could pull her and talk to her? Give her some time, show her that she can build a relationship with you, that sort of thing.
I'm sorry, may I add one more thing?
Yes, please.
I would also, I don't know if this is already happening, but I would also recommend for the parents to attend therapy because there's so much guilt and shame, and sometimes other relatives don't understand the behaviors or the need to be more supportive and understanding. Um, and just to kind of be a community, the whole idea of it takes a village to raise a child. Sometimes we don't have that, and taking really good care of yourself, making sure you're sleeping as much as possible, not skipping meals and doing really healthy things to take care of you because it takes so much out of you when something so serious and so delicate with the person, one of the people you love so much. It's just really intense. So a lot of self-care and counseling is another suggestion that I think would be helpful.
Totally. Thank you so much, Maria. That is the perfect advice and definitely where we're kind of going in this conversation too. But I mean, just hearing a parent say like, this is really hard. I mean, parenting, I always talk about this at least once in the session. It's like parenting is really hard in general. And then having something like this, your child either dealing with depression or with self-harm or suicidal ideation, it's incredibly emotional and difficult. And so absolutely taking care of yourself. I have told people many years the story that when I worked at Rady Children's Hospital, there was one of the psychiatrists there who I was really learning a lot from. His name was Dr. Connor. I think he eventually became kind of the psych medical director. I'm not sure if he still is, but he always had this idea that like, when parents get better and feel better, their kids get better, right? So there's this element of like, I know that medical care is not this way currently, and I wish it was, but the reality is when we have parents who feel depressed or feel anxious or dealing with trauma or stress, right, our kids feel it. And so the better we take care of ourselves, the better they get. And that's absolutely true. And also, I recognize really difficult, but we have to prioritize taking care of ourselves in order to prioritize our kids. And it's hard and it's a struggle and it's stressful, but it's absolutely just crucial to do. And so, thank you so much, Maria, for that. Definitely getting therapy for yourself. Would be beneficial just to talk about some of this stuff that's happening. Um, yeah, so this is how we're going to foster a protective environment for our kids, and it goes perfectly with what Maria suggested and kind of got us started talking about, which is modeling healthy ways of managing stress to our kids. Now, sometimes, right, especially when we have kids who don't want to go to therapy or they refuse therapy, sometimes us getting in and saying, you know what, I'm going to go to therapy, right? We're modeling that to them. And so we might model exercise, we might model movement, we might model good nutrition and like Maria was saying, eating really well and not skipping meals. We might model talking and going out one night a week for an hour with our friends or whatever it is. We can model these healthy ways, right? Maybe it's I can't do anything or pay for anything, but I can model meditation at home. I can model doing mindfulness exercises for 15 minutes after dinner or um, whatever that looks like. We really want to help model that. And the reason why we foot stomp modeling so much, particularly with children and adolescents, is because of mirror neurons. This is basically what's happening is kids are the way that their brains are wired is to completely mirror what they see. And so I always tell parents, your kids do not do what you tell them to do, they do what you do. So if you're doing the thing that you want them to do, they will follow suit eventually, right? Now, if you don't want your child to yell, but you're yelling, right? This is where modeling and mirror neurons come in. If you are eating well, right, then the kid's going to eat well. If we do exercise or movement, we see that the kids do it. If we smoke cigarettes, we find that the kids smoke cigarettes, right? So it's very much so the way that the brain is wired. And this is one helpful avenue to really focus on is like, okay, I'm going to model deep breathing when I get upset instead of yelling. I'm going to model therapy or exercise. And we can really help kids learn healthier ways to manage stress just by watching. Um, in these scenarios, we want to, whether a child who is depressed or a child who is showing some of these symptoms or a child who is dealing with suicidal ideation or self-harm, we want to keep the lines of communication and exchange open. We don't want to shut down, right? Even though that's sometimes what we want to do because of the hurt or the guilt or the fear or the worry. We want to keep that open. We want to encourage you guys to emphasize and uphold the importance of family time, whatever that looks like for you guys, whether it's nightly dinners, whether it's weekends together, whether it's special like one-on-ones with that child or with each child. We want to keep up with the expectation that children contribute to the family's chores and responsibilities, right? This is something I call family contributions. We've talked about this in previous conversations, particularly on positive discipline. We talked about family meetings and setting boundaries and expectations for our kids. If you miss those, definitely go back and check those out. Um, Setting limits and consistently enforcing the consequences when the boundaries are violated. Um, Respecting the development of your child's individuality. We talk a lot about providing firm guidelines around technology, particularly with kids who struggle with self-injury. They self-report spending several hours a day on the internet with other people who self-injure via message boards, text messaging. A lot of that stuff is unregulated. And then they engage in their self-harming behaviors, right? And so some of the information shared is really supportive. Some sites actually encourage self-injury and share self-harming techniques. So we want to make sure that we're supervising the technology use and possibly limiting technology use when it comes to that. Um, I typically talk to families in a risk assessment scenario about removing self-injury tools, but initially I would say don't go to that first, right? We don't want you to go take away all the tools because if kids have a strong desire or urge to injure themselves, they will find a way, and it might not be as safe as the ways that they're currently using. And so I know this sounds surprising, but sometimes the panic of losing that control can actually trigger more harming episodes. So we want you to seek the help of a professional or an expert in those cases, and they can kind of help you with the best way to do that. We talk about like respect, right? We've talked a lot about this with relationship in the context of the home. It's a two-way street, so we want families to keep the atmosphere inviting, positive, upbeat. Positive emotion promotes resiliency and it serves as a protective measure. So the more we get like negative, um, you know, cold or distant, that kind of changes and it takes away those protective measures. And so you can practice coping skills together with your kids. If your child's really overscheduled, we can kind of cut back on some of that and take off some of the pressure to perform or the pressure to be at all these meetings or all of these games or with all of these extracurricular things. Um, and the reality is there won't be a quick fix, but getting the professional help, getting the expert help is going to be definitely getting your child set on the process. And there are definitely just different stages of change for each child, and it will vary. So trying to kind of do some of these things, reminding yourself that we can help. And I think the predominant way that we can help is this conversation that I have had with you guys, or those of you that have been in previous classes about the relationship. And we talk about parenting in the context of warmth. And for those of you guys that were around for the conversation of like authoritative versus authoritarian versus permissive parenting styles, we want really high warmth. We want high compassion with our kids, right? We want acceptance, low hostility, lower parental control. Now that doesn't mean none, right? As I've told you guys before, and the concept of authoritative parenting is high demand, high warmth. So we have good parental control, but in the context of high warmth, right? We don't want to have really high parental control and low warmth, or really high parental control with a child who has earned more responsibility and more privacy and more individuality. We want to kind of respect that. So kids with less warmth, less acceptance, high hostility, and high parental control, those kids are more likely to develop clinical depression. And so we know that there's this correlation between parenting style and depression, which means we really want to be aware of how we parent, and we really want to be aware of what kind of atmosphere we create in the home and how we can kind of help the situation. Um, One thing that we really recommend with kids who are either struggling or to prevent depression, high quality interpersonal relationships. And this means it doesn't have to be with you. It could be with a mentor, it could be with a coach, it could be with a grandparent or an uncle, an aunt. We really want undistracted, one-on-one, high quality personal relationships because this is what keeps kids from isolating, right? So if they're isolating and they don't necessarily want to talk to you, let's find somebody, right? Um, and so for a lot of people, I think we've also become more of a digital age and more of a digital relationship world. And we really want to shift that because that's part of what's keeping kids in this kind of like isolative withdrawal state, and it's normalizing that more, which we know causes problems. So we want to definitely increase their relationships with others, whether it be, like I said, a coach, somebody at church, somebody in the community, somebody in the neighborhood, a family friend that you trust and that they trust. Um, we talk a little bit about healthy adaptive coping, emotional regulation. There's an exercise that I am going to send home with you guys to do on thinking errors. And this is basically just a thought exercise. We know that with depression, negative, what we call negative cognition or negative thinking or negative thoughts are really common. And so what we try to do is help people reframe their thoughts, kids that are having really depressive, negative thinking. We can kind of transform their way of thought by doing some of these exercises and practicing and repeating. Healthy adaptive coping, that obviously looks like a variety of things, right? Exercise, movement, sports, reading, journaling, right? Being outside, hiking, yoga. We could think of all the things, riding bikes, right? Like spending time with friends, creative outlets, meditation, mindfulness. These are healthy adaptive coping mechanisms versus isolating screens, YouTube, movies, video games, right? Like we also talk about maladaptive coping like drugs, sex, gambling, all of those types of things. Um, but those can also be like addictions to screens or addictions to video games. Some of those more not healthy coping skills that kind of make things worse. Arguably, sleeping too much, right? Those kinds of things are all going to be considered maladaptive. So we also see this correlation between resilience to depression and the quality of peer support. And you remember I talked earlier about I've seen so many kids where the reason they came to me in the first place was because a friend shared what they talked about or something concerning that they said or did with one of the school counselors or with the parent. Typically, it's the school counselor, but what we see is that quality peer support, it appears predictive of resilience to depression. So if kids have a good social circle, right? You hopefully know your kids' friends, hopefully you know their names or you've seen them, you've met them or their parents. The reality is when kids have a good peer support network, they tend to appear more resilient or are more resilient to clinical depression, which is a wonderful thing. We can get our kids involved in specific hobbies, clubs, sports, programs to encourage them to meet healthy friends, whether that's community, church, social organizations, school related, whatever that looks like. We really want strong social support network for kids, both with other kids and with healthy adults. Here's here are some healthy ways to support your students. So we're going to kind of go over this slide. And actually, I didn't pause for questions yet, so I'm going to take any questions that people have. There's Annie's throwing some stuff in the chat. She put a copy of the presentation, and I think way up, um, Annie, I sent you the handout, right, for the presentation.
Yes, do you want me to drop it now or?
I guess you could wait. I was gonna throw it in there just as like prepare people, but then if anybody puts in the chat, then people will miss it. So yeah, you put it in when you got this. You know what to do. Um, I just wanted to be sure that I sent it to you and I didn't forget. Okay. So what I'll do now is kind of pause for questions. If anybody has throughout of all the conversation, I know we talked about a lot. I still have kind of more ways to support your student. We can talk about, how to build resiliency to depression in those ways. Does anybody have any questions about what we've talked about? Concerns, comments, questions you want to share? That way I don't just keep talking and then people miss their chance. All right. If nobody has any questions, I'll just kind of keep trucking. Um, all right. Okay. Ways to support your student or your child. Obviously I use those words interchangeably because this is coming from, right, a school perspective, but ways to support your child. Talk to them, right? Show them extra love, extra support, extra caring. Now, I think there's kind of a way to do this in a way that is possibly more healthy or something that maybe they'll be more receptive to. Um, we want to kind of we don't want to minimize what they're feeling. We really want to try to validate. We don't want to dismiss their feelings because either we disagree or we feel like they're wrong or we feel like, "Ugh, but like that shouldn't make you feel this way," right? We just want to empathize and validate. I think in one of the previous sessions, if you can get access to the PDFs from the previous sessions with the videos, we did some actual validation language, right? And that sounds something like, um, you know, I can imagine that you would feel that way, right? Or I can really understand that you know, somebody in your situation would feel that way. Or I'm here for you. I can listen, right? It might sound just like a really basic statement to validate, man, that must be so hard. Does it feel scary? Does it feel like you're alone, right? Asking questions. We just want to validate. We just want to empathize with them. And the reality is, some of you have kids that are like, they don't want to talk to me. And I think that's probably one of the biggest struggles because then we feel completely helpless, right? Because they're not wanting to communicate with us. And I think the best scenario there, or the best strategy that I have, is just show them that you care, right? And that can be little things that you do, whether it's like bringing them a lunch that they really enjoy on the weekend or cooking them their favorite food or um asking if, hey, I've got some time on Saturday. Do you want to go out for an hour? Let's go do whatever you want to do, right? And they might, if it, you could find something that's low cost or free, right? Let's go walk by the beach, or let's go take a walk outside, or let's go hike on one of the trails. Let's go bike. Um, let's watch a movie together. What do you want to watch? We can watch something for an hour, right? We're just going to connect with them, and it might be doing something small that's nice. It might be something, oh, I remember that you said this, and so I did this for you, right? If your kids don't want to talk to you, it really means that there's a fracture in the relationship. And so doing those small things can help rebuild that, right? And you might even say something like, look, I know you don't want to talk to me, but I want you to be able to talk to somebody. So I want to get you some help, or I want to take you to see somebody. And that way you can just talk because I know you don't want to talk to me, and that's okay. Right? We might just normalize that whole process or that whole thing that's happening. But we absolutely want to try to talk to them, right? Let them know that we're there. Let them know that we're standing by. We're here to provide help, support, right? Here to connect them with help. Um, and I think doing some of those small things that they really like or that they really want, but normally either we don't have the time, the energy, the desire to do those things. Sometimes that can just help bridge that gap and then get them to a place where they feel like they could talk to you, even if it's just for a moment or it's for one day, right? We just want to get them to a place where they feel heard, and that we can get them some help. We also talk a lot about, in the context of clinical depression or just like stress in general with kids, modeling from parents appropriate emotional awareness and coping. And this is something that is really a struggle because I feel like a lot of us were not taught how to do these things. We're kind of learning as we go. And yet, the most important thing that we can do for our kids is show them what we want them to do and do it, right? Do model that in front of them. Because I said it earlier, our kids do not do what we tell them to do, they do what we do. And so, if you're modeling appropriate emotional expression or awareness and you're modeling good coping, they absolutely will see that. And it is within their brain, they will mirror it, right? Whether they want to or not, it will happen. We just have to do the modeling, which is sometimes the hard part. Um, I would encourage doing some of these thought exercises with them. On the next slide, when we get to that, Annie's going to drop a worksheet in when we're ready, and that is going to be a really helpful thing to do with your kids, especially if you've heard them say certain things like "I'm the worst," "I'm a loser," "No one likes me," "I can't do this," right? You could even do some of those things that you've heard them say, and you can help them practice this like thought exercise and just give them the knowledge that, look, a lot of this is stemming from the way that you're thinking and the way that you view yourself, and we can change that, right? Doing it with them, especially if you've got a decent rapport and decent relationship, can be really helpful. Uh, get them a journal. Get them a nice little journal from one of the places that you shop. Um, Either model doing it with them, schedule writing time with each other, or, for coping, like, look, I got these new journals. We're going to do it together. What do you think about sitting out on the porch for 15 minutes and just writing about our day or about our emotions, about what's going on, about our fears? Um, and showing them, look, okay, you think it's silly, you think it's corny, I'm going to do it, right? After dinner, I'm going to sit here for 10 minutes and I'm going to journal. And eventually they might get curious about that. Um, Especially kind of scheduling that into your day repeatedly, right? We're modeling that. We're going to encourage them to find a support network, right? Healthy outlets. We might encourage them to spend time with friends. We might plan for that each week and facilitate that each week, right? Some sort of healthy support network, a friend that they've talked about. Obviously, we want to know, are these good friends? Are these healthy friends? Are these appropriate friends versus not? And you're going to have to use your judgment and figure that out. Ask them what kind of people their friends are. Ask them how they make them feel when they're around them. These are some techniques to figure out what kind of friends your kids have. We talk a lot about promoting exercise and a healthy diet. for almost every person that I've ever seen who has depression or anxiety, I encourage them, at least on the first visit, to reduce, if not eliminate, sugar. So that's a tough one. I currently do no sugar, and it has drastically helped me both in my mental health, my physical health, just everything. It's incredibly difficult to do, I will say. And yet at the same time, minimizing or eliminating sugar, which is what I do. I have natural sugar like fruit, and that's it. But it will absolutely scientifically supported will decrease your anxiety. So if you struggle with anxiety, cut out sugar and after a month, see what your anxiety levels are like. It does work. But in general, promoting a healthy diet, minimizing sugar, caffeine, processed foods, colors, things like that. These things will help. And we find that exercise is just as effective, if not more effective, than medication. And so we don't want you to do this in lieu of seeing your doctor, but the power of exercise and movement, particularly with against depression, is incredible. Um, so we also want you guys to take him to the doctor. You don't have to force therapy, you don't have to force counseling, but you can offer this as a way to help. And most certainly, we want to take them to see the doctor, get it just, an expert to talk to you about it, give you some resources, kind of guide you in what you can do. Maybe they can talk to your child as well. That can be kind of helpful in a really kind of compassionate way. Sometimes they might have better luck saying, "Hey, I really think that you need to see somebody." And if it's coming from somebody else, I think we all know that too well. Sometimes our partner or our parents or somebody can tell us a million times that we need to do something, and we hear it from someone else, and it's really helpful. So take them to see the doctor. The doctor can sometimes help. Um, oh no, this went all the way back up. So we have a parent who's been disconnected. He does not talk to me and to anyone, does not want to get help. I would like to know if there's a way to encourage him to open himself with someone. Um, I think the reality is uh, for a kid like that, you might have to intervene in terms of putting someone on his path or putting him in someone's path to help him. Because if he's very avoidant, and resistant to the idea, like I said, maybe calling the school or calling the school counselor and just sharing your concern and saying, I just want you to meet with him. That might be something that gets somebody in his path that can help. And I mean, he might like the person, right? He might be able to go in and maybe they just play card games for a couple weeks while he gets comfortable. So sometimes I think you, in a situation where they absolutely don't want to get help, they don't want to talk to you, they don't have anyone else to talk to, putting someone in their path might really help. So, like, either take them to the doctor, right? Checkup, general checkup, that's what you're going under the guise of. And when you get there, maybe you talk to the doctor separately for sure. Just let them know your concerns. Maybe the doctor can help, kind of convince, hey, I really think you need to see someone, or, this is what this sounds concerning, or they can kind of come up with a way to say, look, this is not normal, and you don't have to feel like this by yourself. And like I said, sometimes hearing that from someone else can be really helpful. So in those situations, I would say if you're modeling all of this, you're managing your stress, you're showing your own healthy coping. Yeah, take them to the doctor, get them to try to intervene. Um, Maybe a family member or a friend that they really identify with or can relate to. get them to kind of plant the seed or say, hey, I really think you should talk to somebody, right? Because it's more about trust. Um, but some kids and some people will just withdraw, right? And especially as kids get older, it's harder for parents because I think a lot of times our hands are completely tied when it comes to older kids. Um, and older kids get to a point where we've given over the keys to the house, so to speak, and they have to start making their own decisions for themselves, right? Um, so you tried with the school counselor, you tried with the doctor. Yeah, I'd be interested, what happened with the school counselor or what happened with the doctor? It just like, because the school counselor could be convinced to just meet with him like once a week. Um, and that could be helpful until he kind of forms a relationship with that person. Because kind of going back to that conversation of once our kids become teenagers, we realize, we can't make them do things, especially to make them get better, right? And that's really hard as a parent to sit with. Um, and yet my recommendation and best strategy would be start building your relationship. Why does he not want to talk to you, right? There might be some historical stuff, and that's totally relevant. I would validate that. I would say, look, I know there was times when I didn't meet, you know, I wasn't great. And I know that as a parent, and I'm sorry, right? Apologizing, trying to repair, because that is going to be the thing that will get him on speaking terms with you. Again, it might be a family member, a coach, somebody at church, somebody in the community, somebody in, sports, or if he does anything or extracurricular, I would say school, the school counselor. You could mention your concerns to them and say, hey, he won't talk to anybody, but I need you to do that. What are the laws in healthcare? Okay, Lynn says he's refused to see the counselor, but I'll try to rebuild trust. I mean, that's going to be, yeah, regardless, just trying to repair your relationship with him and rebuild trust is going to be incredibly crucial because he needs somebody that he can trust. And I know it's hard and it's a big task, and yet you care. You showed up and you care about him and you're worried about him because you're telling us, right? And I hear you. So I think eventually he will see that, and that rebuilds trust too. Um, what are the laws in healthcare for teens to go into the visit doctor on their own right for half appointments? I don't know what the question is, Nancy, but uh, kids in California can consent to care at 13. So I don't, if they're 13, then they can meet with the doctor, they can make decisions. So I'm not sure. I don't know what half appointments. Go into the visit doctor on their own. That's the best answer I can give you. If you could clarify a little for me what the question is. Okay, great. Yeah, kids in California, they can make medical decisions for themselves at 13. All right, let's go to the next slide. Thank you guys for all your questions and feedback. And I really hope that these strategies are helpful. And keep coming back if you need more, because we're going to do some more classes. Okay. So in the chat, Annie has posted the challenging the thoughts exercise. Please open that up, screenshot it. That is one that you can do for yourself. It helps with your own negative thinking. It will help with your kids. You can teach them how to do this, do it together. Say, hey, I just went to this class and I got this thing. Will you do it with me? Or let's sit down and do it together. It could be really helpful because what we're doing is we're teaching them how to reframe their thoughts and how to challenge those negative thoughts and not just take that stuff as gospel, so to speak, right? Um, oh, you guys are so welcome. There's a question. Is there a mental health equivalent to before or after school care? Kind of like Boys and Girls Club, but with an explicitly mental health focus while parents are at work. There is nothing that I know of that exists like that. Annie's shaking her head. That would be lovely. Um, but no, there is not, unfortunately. Okay, great. So there's a copy of the presentation. There's a copy of the challenging thought exercise. I'm going to go through to the last slide, which is questions, comments. Annie's information is there. Of course, my information is there. I have a couple minutes to take questions if anybody has other questions that they need answered or comments, feedback, concerns. Anything that stuck with you that you're going to take home tonight? Oh, you're so welcome. I'm so grateful for each and every one of you that came. I thank you for your interest and for your effort because I know that your kids, maybe they don't see it because they're not here and they don't get to see you doing it, but you're investing in yourself, you're investing in your partnership with your kids, and it's wonderful to see. Maybe that's something if we have kids that don't want to talk to us, right? We could say, look, I'm going to go try to be better. I'm going to go do some parenting classes so that I can be better for you, and I'm going to try, right? And that might be something that can just help build the relationship. Time did go fast. Time did go fast. Thank you so much. Time goes by fast anyway, doesn't it? I don't know. I feel like we're on fast forward lately. My husband tells me it's like some sort of hydrogen machine or something. I don't know what that means, but time's fast. Okay, any questions? I'll go ahead and take them. If you guys don't have any questions for me, Annie's putting the positive parenting program information in the chat. She's got a copy of the presentation and a copy of the take-home exercise. I can stand by for a couple minutes if you guys would like. If no questions.